Now we move on to the next lecture. The topic of the lecture will be non-muscle invasive bladder cancer management in an era of BCG scarcity. Over to you, sir, moderator, to introduce the revered speaker.
It's a pleasure to invite Dr. M. Sivashankar. He's a consultant urological surgeon from District General Hospital, Hambantota. He's going to talk about non-muscle invasive bladder cancer management in the era of BCG scarcity. Over to you, Dr. Sivashankar.
Good afternoon, everyone, and thank you, Taha, for the kind introduction. And thanks, SLAUS, for giving the opportunity to me. So I do not have any disclosures. The non-muscle invasive bladder cancer is so if you see the bladder cancer is the second most commonly diagnosed cancer in the men. And among those, the 75% is the non-muscle invasive. It's confined to the mucosa and the submucosa. So among those, the 20% has the risk of recurrence and the progression to muscle invasive disease. That's why various risk stratification came. The latest one is the EAU non-muscle invasive bladder cancer prognostic risk group. Everyone familiar with it. It's mainly categorized into 4 groups: in the low risk and the intermediate, high risk, and the very high risk. And why this is important? If you see, the low risk has less than 1% of progression to muscle invasive disease in the 1 year and the 5 years. At the same time, if you see the very high risk, it has the 16% of chance to go for muscle invasive in the 1 year and the 40% in the 5 years' time. So this is a quick summary of management based on the risk stratification. If it is a low risk, the TURBT with a single dose of MMC is enough. If you come to the intermediate risk, it's need the full dose of intravesical BCG, the induction for 6 weeks and 1 year course of full dose of BCG. If you go to the high risk, again the BCG, induction 6 weeks and 3 years of maintenance therapy. And the very high risk, there's a high chance of probability to go to the muscle invasive disease. We need to discuss with the patient for the immediate or early radical cystectomy if they agree. If the patient is not agree, they need to go for the 3 years of maintenance of BCG. So that's why BCG plays a key role in the NMIBC management. So the BCG is used for this bladder cancer management for more than 40 years. It's induced the immune system and create the anti-tumor activity in the bladder, and that's why it's protecting the bladder mucosa from the recurrence and the progression. There are a lot of various strains used by various countries, and at the same time, the most common reason for the BCG intolerance or the discontinuation of therapy due to the side effect profile of the BCG. If you see the BCG supplies, the chart shows a lot of countries, they are using various companies' brand. The Tice is the commonest brand used in the America and the most of the countries. And what happened in 2017, one of the famous company went offline 2012 and is closed permanently in the 2017. Then the global supply is mainly dependent on one company, pharmaceutical company. The Tice BCG brand was produced by the particular company, but the usage of BCG is gone or grown up by the world, so the particular company can't able to produce enough amount of supply to the world. So they put a recommendation, they are going to produce more BCG, but it will take a lot of years to produce enough supply to the world. Then the demand goes up and the supply from the company is not come. That's why it's become a big issue in 2018-19. A lot of issues came in the article related to the BCG shortage. And what happened, that's the time all the urologists, oncologists, and the researchers think about what are the alternatives we need to do for this non-muscle bladder cancer management instead of BCG. A lot of articles, they came, so they started thinking about what are the alternatives available instead of BCG. So because of all the urological associations, especially the AUA, they put a good recommendation, what are things we can follow during this shortage time period until the particular companies produce enough amount of BCG supply to the world. The first recommendation is everyone is following the BCG should not use for low-risk disease. The second recommendation come to the intermediate risk. So initially, the ideal management is the first line is the BCG. So instead of BCG, we need to think about other intravesical chemotherapeutic agent like mitomycin C or gemcitabine or epirubicin or docetaxel. So what are the evidence behind this? A lot of researchers came up after 2018. They just put the findings and still the BCG in the top, like BCG reduced the recurrence over the time. But here in this paper, they couldn't able to find any difference of risk of progression or the risk of death from any cause. But whatever the other agents, they have the less side effect profile than the BCG. So if you selected MMC for the intermediate risk, there are various ways to increase the efficacy of MMC. You can adjust the dose, keep more like 1 hour rather than 30 minutes of duration and alkaline the patient and make him more dehydrated. There are various devices available to increase the efficacy of MMC like hypothermia intravesical chemotherapy or microwave-induced hypothermia effect. This is used if we select the MMC as a maintenance therapy for the intermediate risk. These are the ways to increase the efficacy. And another intravesical therapy is the intravesical gemcitabine. This paper they found the gemcitabine is a promising effect in the absence of BCG. It's reducing the recurrence in a population. When they compare with the mitomycin C, only 70% of the population, they found the recurrence. But if they compare with the BCG, still the BCG, full dose BCG maintenance is superior to the gemcitabine. But various papers show various findings. Then come to the high-risk group. So high-risk group, again, is indicated for the BCG for the full dose induction and the full dose maintenance. So there are a little bit of alteration in the recommendation. So if you can't get the full dose or supply, or if you need to reduce the dose to 1/3 or just dilute the dose. And the second thing is if you get enough supply for 1 year, so not to give the maintenance for 3 years, reduce the duration to 1 year. So why this BCG dose reduction? Sometimes less is better than nothing. So we can get the good cytokine response even with the 1 in 100 dilution of the standard dose, but that's not enough to get the full protection in the bladder mucosa. So a lot of studies is going on for the dilution. So then they found the 1/3 or half dilution gives some promising effect in protection of the recurrence or progression. So these things we can do in the BCG therapy. Either you can reduce the dose to save some BCG, or go for, rather than depend on particular one company's BCG, go for the other company's BCG, and you can use until the time. And you can go for a combination therapy of intravesical therapy with the BCG, or you can go for some systemic treatment with the BCG. So this is commonly practicing in most of the Western world during the shortage time period. They're getting 1 vial diluted to the 3 and giving to the 3 patients within the 2 hours of time frame. So they're saving 1 vial to 3 patients. So then this paper was published in 2018. The full doses were low dose BCG. There are no survival benefit, but in the low dose group, there's a high risk of recurrence. So those patients may need more TURBTs than the full dose BCG. So if the hospital or the country got the enough supply for the maintenance, then they should avoid the 3 years maintenance, should be limited to the 1 year maintenance. This is support for this evidence. The EOR-TCGU cancer group, the randomized trial, they found if you give the 1/3 dose for 1 year and the full dose for 1 year, see in the 5-year disease-free surveillance is 54 and 58, just 4% of reduction. At the same time, if you see for the 3-year maintenance, there's only 2% of difference. That's why they reduced the 3 years to 1 year. The recommendation 4, if the BCG is not available for the high-risk bladder cancer, then we need to think about the alternative, other intravesical chemotherapeutic agents, like gemcitabine or epirubicin or docetaxel, or combination of these two. This study, they analyzed all like gemcitabine and the standard dose of BCG and the low dose of BCG and the MMC and the epirubicin. They found the gemcitabine is superior in preventing the recurrence, but the disease progression is prevented by the standard dose of BCG. But here you can see the low dose BCG still better than the MMC or the epirubicin. The similar study again are the BCG versus combination of gemcitabine and the docetaxel. So the BCG is still superior in 81% of reduction of the recurrence-free survival in 2 years' time, but the combination of gemcitabine and docetaxel, 61% reduction of recurrence. The bridge trial is currently ongoing, so they assess this outcome like gemcitabine and the docetaxel combination with the BCG, and they also found the combination has some superior effect than the BCG. That's another positive finding from these researchers. They found if you give a BCG or the intravesical other chemotherapeutic agent, the cost for the BCG is more than the gemcitabine docetaxel. These are the newer combination therapy, but still we don't know the outcome. So there are the first one is the intravesical NAI, is the interleukin-15 agonist, approved by the FDA in USA, but the research is going on like that. The combination of systemic treatment with the BCG also ongoing trials. Everyone want to find what are the alternatives to the BCG at the moment. This is the TAR-200 is the indwelling device that delivers the intravesical gemcitabine over 3 weeks. This trial also currently ongoing in Sunrise 3 trial. They're also comparing the outcomes, so it's still the research study is going on. The gene therapy also started and Aristin in 2022. All the work started up whenever the big shortage in the BCG in the world. The recommendation from the AUA is if the patient have a T1 tumor with a high risk of features, carcinoma in situ, LVI, or the prostatic urethral involvement or various kit histology, we need to counsel the patient for the radical cystectomy. If they are willing, we need to consider that. Why we need to consider upfront radical cystectomy? There are various reasons. So the TURBT not enough to correctly accurately stage the disease for the T1. So if you've done a TURBT and the patient going for a radical cystectomy, there are 27 to 51% they have the muscle invasive. The second reason, very high risk, they have the very high probability to go to the progression to muscle invasion disease in 5 years and 10 years time. So then we can consider upfront radical cystectomy. The third one, if the patient have a long-standing non-muscle invasive and when they progress to muscle invasive, they have the worse prognosis than the primary muscle invasive disease. So for this reason, it's a very high risk. They may need an immediate radical cystectomy. And the second group is the BCG unresponsive non-muscle bladder cancer. If you offer the radical cystectomy, the 5 years time, their disease-free survival is 80%. So 2 ways of doing the radical cystectomy for a non-muscle invasive bladder cancer, upfront or delayed in the setting of BCG failure. Is there any difference? So if you see the 5 years survival or recurrence-free survival is around 70% for the radical cystectomy for the high-risk group, and the cancer-free survival also almost 80% in 5 years' time. And at the same time, is there any difference between the upfront or the delayed early radical cystectomy? There are no difference, almost equal at the 5 years. So in summary, the BCG shortage is going to stay for another couple of years until the companies produce enough amount of ECG. So we need to think about this alternative or adjustment in the BCG and looking for alternative intravesical chemotherapy. And at the same time, a lot of researchers are working on the clinical trial to find out is there any alternative promising effect instead of BCG. And at the same time, radical cystectomy gives us 100% clearance and good promising effect for the very high risk non-muscle invasive bladder cancer. Thank you.
Thank you, sir. Let me now invite one of the moderators to present the token of appreciation to the speaker.